Hi, everyone. My name is Dr. Rebecca Gilbert. I'm Chief Mission Officer here at APDA, and I'm very excited to welcome you to this special session entitled A Conversation with the Experts. I'm joined by Dr. Mwiza Ushe. Mwiza Ushe, sorry about that. Dr. Ushe is a professor of neurology and movement disorder specialist at Washington University School of Medicine in St. Louis. He has a special interest in movement disorders, including Parkinson's disease, multiple system atrophy, dystonia, essential tremor, and Huntington's disease. And his research interests include DBS for PD and essential tremor, as well as evaluation of dementia and movement disorders. So this time is dedicated to answering questions from you, our audience. So please feel free to type your questions into the Q&A, and I know people are already doing that. And we're going to answer as many questions as we can. So that's what this session is devoted to, and we are excited for your participation. So I'd like to welcome Dr. Ushe to the stage, and we'll start right away answering questions. How are you this afternoon, Dr. Ushe?
I'm doing well. Thank you so much for this opportunity. I appreciate the APDA, and I'm certainly looking forward to engaging with folks.
Fantastic. So as you can imagine, we already have questions coming in fast and furious. And the first question that came in is going to be a tough one, but we get asked it a lot. And that is, can we please try our best to distinguish between dementia and Parkinson's disease, diffuse Lewy body dementia with Lewy bodies? There's so many different terms. Can we bring some clarity to this very confusing topic?
Yeah, this is one of those topics that I wish we didn't confuse patients and communities. And the confusion really is us. It is a confusion of terms. If you look at the brain of somebody who we diagnose with Parkinson's disease dementia and somebody we diagnose with Lewy body dementia at autopsy, so when they've passed away, the brains look pretty much the same. It is the same pathology. It is the same disease process. The difficulty comes in before they've died. So we think about what symptoms came first. So if somebody starts with cognitive symptoms first, so they're having memory problems or they're having behavioral problems, and those are impacting their ability to function in really that first 3 to 5 years of their disease process, and then the motor symptoms start, or maybe they start in tandem, people may tend to say, well, that's dementia with Lewy body disease. But if somebody's had tremor for 3 to 5 years, and then they develop slowness, difficulty walking, maybe balance trouble, and then 5, 10 years into the course of the motor disease, they start to develop cognitive problems, people may say that person has Parkinson's disease dementia. In many ways, there's some of us, I being one of the big proponents, don't think it's a useful use of terms. And so I think it's a really good question to bring up, because this question was brought up at the last international meeting of the Parkinson's Disease Association, and people were on both sides of, should we lump or should we split? I tend to be a lumper because I really do think that pathologically they're the same diseases, but we do have to think about what symptoms are bothering patients the most, and so that's what ends up causing people to split them up.
Yeah, I could not agree more. I also tend to be a lumper in this regard and think of the diseases as like on a continuum, and they're all similar in pathology, and probably will be in the end treated and cured in a similar way. A related question is, what is the actual cause of the dementia and the related psychosis? And what I try to answer to this question is, just like real estate, it's location, location, location. So where the Lewy bodies are, where the damage to the neurons are, that's where you're going to get your symptoms. So if your Lewy bodies are present in the areas of the brain that control movement, you're going to have more of a movement feel to your disease. If the Lewy bodies are in locations that affect your thinking, then you're going to have more the cognitive piece. And the same is true for lots of the other symptoms of Parkinson's. Where your Lewy bodies are is where you're going to have your symptoms. So we think of it as that. But if we can attack that pathology at its core, then we might be able to solve a lot of these symptoms all at once. So I don't know if you would agree with that way to kind of frame things.
Yeah, I would absolutely agree with that. It is really, where is the pathology, and that relates to the symptoms that we have. It is the cool thing about the brain is that you can really figure out what's going on with the patient and where in the brain the issue might be by what that area of the brain does. And so that really goes to this question of what symptoms I have. It is what area of your brain is affected by the disease.
Great. I know there's lots more interest in learning about cognition and how it relates to Parkinson's. We may return to this topic, but we have so many more topics coming in. So let's take the next question, which is the topic of dyskinesias. So just to set the stage, dyskinesias are a sort of abnormal movement pattern that is typically a side effect of taking the medications we give for Parkinson's. There's a complicated relationship between taking the medication and getting the dyskinesias, which we can get into. But the specific question deals with dyskinesias manifested as shortness of breath. What is your experience with this particular type of dyskinesia, and how can they be eliminated?
Sure. So certainly this is a rarer dyskinesia for patients to experience, but absolutely one that I've seen with patients. And this tends to happen at peak dose, meaning you've taken your medication and then it peaks and you're getting maybe maximal benefit. And you may have other dyskinesias that come along with it. And then shortness of breath, that isn't really the same shortness of breath as if you've run a mile or you have asthma. It is that you are not able to coordinate the way that your muscles are working as well as you would want, because even those breathing muscles are dyskinetic. And so I would tend to try to manage that in the same way I manage other dyskinesias. I think about, are you on too much medicine? If we can reduce your dose of medicine, that typically ends up being the best way of managing dyskinesias. But we can't always do that, because then your symptoms of Parkinson's may be more bothersome. Your tremor may come out, the rigidity may be more of a problem, the walking and the balance, or even cognitive or emotional issues that levodopa tends to help. And so then we ask, is there something else we can do? We have medications that we can try that reduce dyskinesias, amantadine being our typical medicine that we try to see if it can reduce dyskinesias. And then if the dyskinesia is really quite bothersome and we're stuck with not being able to increase or reduce medications or change the way in which we're dosing the medicines, we think about the surgical treatments for Parkinson's. And now just out, maybe a way to treat the Parkinson's that will help us with smoothing out benefit, maybe these more continuous delivery of levodopa. So the levodopa infusion pumps, either the Duopa pump that's been out for a long time, or now the subcutaneous levodopa infusion. So we're really trying to reduce that peak. So hopefully you don't get to that point of dyskinesia, or if we're able to treat the dyskinesia itself, treat it directly.
Fantastic. And that actually answers Susan's question, which came in, to discuss the pump, which you just mentioned. And Susan mentioned scientists have attempted to increase absorption of levodopa entering the bloodstream. What Susan, just to clarify, what Susan means is, as you said, it evens out how much medication kind of enters the brain by giving this continuous infusion. So hopefully, Susan, you gained a little bit of insight into that new approach, which has just been approved. So that's a very exciting new option. We also addressed Stephen's question a little bit, who wanted to know, how do I know if I'm taking too much or too little Parkinson medication? So as you said, you look at the side effects. Are you getting side effects? And one of those side effects would be dyskinesias, and trying to titrate the medication so that you're getting the good benefit and not getting side effects. And that's really, really what it's all about, Stephen. So let's just address the second part of Stephen's question, which I think is a great one, which is, what questions should I ask when I have my appointment with my movement disorder specialist? So this is the great opportunity to speak to your patients, all of our patients.
What a great question. I'm going to turn it around to, what questions should your doctor ask you, so that you know when you've gotten through your visit that you've actually gotten what you should expect from that visit. So your doctor should be asking you, what medicine are you taking? How is it working for you? What's your schedule? And how in your schedule do you notice it kicking in and wearing off? And are you able to stay on for the majority part of your day? They should also be asking you, what side effects are you having from your medication? These include motor and non-motor side effects. So are you having dyskinesias? Are you having ups and downs? Are you having sleepiness? Are you seeing things that aren't there? So psychosis, hallucinations. Are you having trouble with impulse control problems? So gambling, overeating, hypersexuality, those kinds of things. Are you having lightheadedness when you stand up? Are you having urinary problems and constipation, those kinds of things? And then they need to know about your balance, being able to work through, are you falling? Are you at risk for falling? And then this is the question my patients don't like me asking them, but I want to make sure that we always discuss it is, are you exercising? As hopefully questions will come up in the future is, do we have a disease modifying therapy for Parkinson's? Well, we might not have a medicine yet that increases your time that you're going to live as well as live well with Parkinson's. We know that exercise both saves brain cells and helps patients do better longer. And so from that standpoint, I always ask my patients, are you exercising? 30 minutes a day, 5 days a week, 150 minutes a week, and something that gets your heart rate up. And then they should be asking you, have you done therapy? Have you done physical therapy, occupational therapy, speech therapy? All of those things have been shown to help with balance, to help with your ability to function on a daily basis, to help with voice and swallowing. And then they should be asking about your cognitive function. How's your memory doing? How's your ability to handle your finances? How is your ability to drive? Are you seeing things that aren't there? Are you hearing voices? How are those things impacted by your medications? Should be asking you about your mood and anxiety. Should be asking you about sleep. And then they should be asking you about bowel and bladder. And then whether or not you're taking any medications that could complicate the therapy of your Parkinson's. So any antipsychotic type medications, nausea medications, those are the things that if your doctor hasn't gotten through those things by the end of your visit, you should be asking those questions. Hey, we didn't talk about exercise today. Hey, we didn't talk about constipation today. You know, those things are the key items as you get through a Parkinson's visit. The things that are hard when a patient asks me that we often don't have answers for is, one, how much time do I have? Nobody has an answer to that question. At every stage of Parkinson's, we have no idea in a good way to tell you that the answer to that question. And so you're going to get a very non-committal because we just don't have enough information to be able to give you the answer to that question. You should be thinking about advanced therapies. When is the right time to be talking about an advanced therapy? So something like deep brain stimulation, one of the infusion pump treatments. When is the right time to take care of those things? And certainly, you know, at least once every couple of years, you should be talking about life planning. What are my goals? What are the things that are important to me? What are the things that I want to be able to do that I find helpful? What is my status if I should have a heart attack or any of those things? Have I talked to my family about what my plans are? Not because we think you're going to die sometime soon, but because you want these things planned out while you're certainly able to make sure that you're the one planning those things out.
That is a wonderful list. And you're so right. It's not up to the patient to create the office visit. It's up to the doctor to make the office visit full and meaningful. So thank you for that clarification. I thought that was great. We have so many questions. Let's go to the next one. So you mentioned this motor, non-motor thing. So patients with Parkinson's obviously have problems moving, and they also can have a whole bunch of problems that are not necessarily related directly to movement, but can be very problematic. And Bob talks about one of them, which is mental fatigue or fatigue in general. And what is your approach to, when you hear this complaint, what is your approach to trying to treat it?
Yeah,
It's a really hard one.
It is a really hard one because sometimes the problem is me and the medicines that I've given you. And so that's my typical first place to go is, are the medicines I'm giving you causing part of the trouble? Our great friend levodopa, one of its consistent side effects is fatigue. And so that means that I, as a physician, need to actually start you on that medicine in a reasonable way. And so you'll see us start it very low and go slow with that titration so that we really are giving you the smallest dose that you need to improve your symptoms without giving you side effects like fatigue. And most of our other medicines that we give you to treat your symptoms, to treat your motor symptoms of Parkinson's, and even some of your non-motor symptoms of Parkinson's, fatigue is a potential side effect. And so we're really looking at all of your medications. And sometimes fatigue is your blood pressure is too low, which is one of the things that absolutely happens in Parkinson's. People who used to have high blood pressure as a problem now are dealing with low blood pressure. But we as doctors sometimes don't ask that question. And so you're still taking your blood pressure medicine. And your primary doctor hasn't asked you that question. Your cardiologist is very happy that your blood pressure is now in normal range, But when you stand up, that blood pressure drops and you don't feel like you have as much energy. So it's my job when I talk to you to ask you about your blood pressure so I can be telling whether or not that fatigue is related to your blood pressure. Because often the levodopa and the Parkinson itself are enough now to handle your blood pressure that we can take you off your blood pressure medications and even may need to give you medicine to increase your blood pressure or certainly increase your fluid intake so that you're drinking enough water. That's one of my other big arguments with patients because they don't love drinking water because it's a lot of trips to the bathroom, but that water is so critical to people doing well. I tell them 64 ounces a day. What our mothers told us when we were kids, please drink at least 64 ounces a day. They don't like that. I don't like that, frankly, because it's a lot of trips to the bathroom, but it really is important for people's care. And then we do talk about, are there medications we can give you to increase to increase your ability to have more mental sharpness? And so it might be that you've got some depression. It's never a surprise when people with Parkinson's get depression. It's the same pathways that are affected in Parkinson's that affect people with depression. So it's not a surprise. It's not a thing that you have done wrong in particular. It's part of the disease. And often depression can present itself as fatigue. And so we ask questions around that, not because we think, lots of patients, I'm not actually depressed. And then you ask questions and there's lots of apathy and lack of a desire to do things. And those things can be greatly improved by allowing your body to have more serotonin, just like we give you more dopamine by giving you a medicine like carbidopa, levodopa. Giving you an SSRI may give you more serotonin that gives you more energy and an ability to engage with life. And then we talk about sleep. Sleep is so important in Parkinson's, but sometimes so hard to get. And sleep can be affected by multiple things, sometimes affected by the motor symptoms of the Parkinson's itself. People can have restless legs or can have their tremor come out when they're trying to lay down to go to sleep. That may make it difficult for them to go to sleep, or they may feel like their medicine wears off in the middle of the night that prevents them from being able to go to sleep. And so really figuring out is, do we need to treat the sleep itself primarily, or do we need to treat the Parkinson's better to help people sleep better so that when they wake up in the morning, they're fully awake and aware? Sleep apnea is also a big thing that happens in Parkinson's that results in fatigue. And so I'm a big fan of having patients be evaluated with sleep studies because you might need CPAP, and CPAP is really quite effective at helping people have more energy and certainly has many other health benefits.
Fantastic. I think just listening to you, I think one of the take homes for our audience should be, if you have a symptom, it's not like symptom treatment. The symptom has to be evaluated. It's like a puzzle. And one approach, you may want to try one approach, it may not work, then you try another approach, and it's really working through the possibilities to get to a solution. And so I think the take home message is, don't give up. Ask your doctor again. There may be another approach, another thing to think about, another thing to try to kind of get to the bottom and to really improve your quality of life. So, thank you for that analysis. I think that's really critical for people to hear. A question from Carla, which is a question that we get asked all the time. Let's talk about the relationship between taking carbidopa, levodopa, and food.
Yeah.
Should it be taken before meals, after meals? How much time should you wait before or after eating? Do you like to tackle that one?
Sure. As with everything I've said today, it depends. And not everybody is affected by food. However, the typical advice from us is to try to take your medicine about a half an hour before you eat. Protein can interfere with the absorption of levodopa, and so you might not get as much into your system. However, this is why the depends came on here. Some people, when they take it on an empty stomach, get pretty nauseated with it. And so for those folks, we do recommend, hey, maybe take it with a little bit of food, maybe not a high protein thing, maybe some crackers or bread that allows you to be able to digest the medication well. I have lots of patients who take it at meal times and it works perfectly fine. And so especially for patients where, man, I'm taking medicine every 3-4 hours. You're telling me to try to schedule it with my food. I'm just not figuring it out. I say, you know what? See what happens when you take it with food. If you notice that, boy, that dose is not kicking in quite as well, you can certainly try to dose it a half an hour before or an hour after a meal. But it's going to be something that we work out very individually. It's one of the things that, I'd love to have a conversation with patients about because, a community like this is an awesome thing because it allows us to be able to support each other. But one of the things that can be difficult in a community like this, where we see each other with having the disease, is we can think what works for you is going to work for me, that my disease is your disease. It really is a very personalized treatment that we try to get to for you. And so that's why we ask you in particular these questions over and over, because we don't expect the person next to you at your Rock Steady class to respond exactly the same way that you do to medications or treatments or therapies. We're really trying to gear it directed for you.
Excellent. There are a couple of questions that have sort of shorter answers, so let's tackle a couple of those. There's one from Kelly, which is generally how long do patients on a new medicine stay on the medicine to see if it's effective? And again, this is dependent on the medicine. For variations of carbidopa-levodopa, I like to keep patients on a dose for 2 weeks, let's say, and then if it's not effective, it can be increased. So that's the thing. When somebody comes back to you and says that wasn't effective, you have to decide, well, is it not effective when we move on, or is it now time to increase it and try a higher dose if there aren't side effects from the lower dose? So again, a very kind of tailored way of approaching these medicines. And then there's some medicines, like say, for example, some antidepressants that you need to be on for 6 weeks before you really know whether the medicine is effective. So it really is a very individual process. And I think one of the take homes here is for people with Parkinson's, the doctor needs your patience in more ways than one to work through these different options. So thank you, Kelly, for that question. And then we have a question from Keith, which is if and when people experience delusions, are they normally auditory or visual? So it turns out that in Parkinson's, they're very often visual, whereas in other disorders, they're more auditory. Why that is not straightforward. We don't really know, but practically that's what we see. We see a lot of visual hallucinations. That isn't to say that the psychosis of Parkinson's can come in the form of auditory or tactile.
Mhm.
Definitely seen patients who feel like bugs are crawling on them and things like that. It's more tactile. So there's no one answer for everyone, but visual is very, very common. So just wanted to answer Keith's question. So this is a question from Sheldon, which is that sometimes Sheldon experiences a buzzing feeling, an internal buzzing feeling. It's not painful, it's irritating. Is that something you've heard from your patients? And what do you think a good treatment option would be for that?
Yeah, that actually is something that we've heard from our patients. Often patients can have an internal sensation of even tremor where they're feeling like they're off, but they look outward and their symptoms are, they certainly don't have their typical tremor. This can even be one of the first presenting symptoms of somebody feeling an internal sensation of shaking while they're not actually externally shaking. This is typically an off symptom. And so it means that your medicine may be wearing off on you at that time. And so the question then is, do we increase your medicine? Do we give you a medicine that maybe lasts a bit longer at night? Do we think through those things depending on what side effects you may be having from medication?
Great. So we have another question. This is from Debbie and Rebecca. I'm going to lump these questions together. Both are interested in sort of natural approaches. So Debbie asks, are there ways to increase dopamine naturally? This is a tricky question because what does that exactly mean? What constitutes naturally for one person may not be naturally for another. So what I think Debbie may be getting to is a source of dopamine that isn't from a pharmaceutical company, potentially. And that leads us to the topic of mucuna, which is a extract of a bean, the velvet bean, which actually contains dopamine in it. And it's an extract from this bean that can be put in a bottle and can be ingested as dopamine. So one may argue that this is also, one should argue this is also a medication. It's just source is from a bean and has to be treated like a medication, just like a medication that you would get from a more traditional pharmacy, and has to be incorporated into your regimen in a similar way. So I don't know if you want to address how you deal with the topic of this sort of natural sources of dopamine in your practice.
So, I do get this question a bunch, and I have. We're always right now in Parkinson's, we're treating symptoms, and so it is about, are your symptoms controlled by whatever you're doing to the degree that you need to live your life in the way that you want to live it, and is the thing that you're doing safe? And so from that standpoint, I always say, hey, I don't know everything, and there may be some natural way, more, well, again, using that word natural is difficult, other ways than pharmaceutical to get more dopamine. But if you're getting it from a source that is reputable, I'm not against it. It's just difficult for me sometimes to figure out how to help you dose that, because it might not be the same every time. And then I have the opposite conversation around our pharmaceutical carbidopa levodopa. We often want natural treatments which help our brain to do the thing it's supposed to do. As I treat Parkinson's, when I teach it, I often think that people understand diabetes better than they understand Parkinson's disease. So they understand that in diabetes, insulin-dependent diabetes, you don't have enough insulin. So what's the best way to treat that? Well, give you something that allows you to make insulin when you need it. And so that's what we do with levodopa. Levodopa is a prodrug that actually goes to the cells that make dopamine, that allows those cells that you've still got to be able to make dopamine when you need it, which is why it remains our best way to treat it, because it actually is the most natural way to treat Parkinson's, because it uses the same machinery you've already got. It's not artificial dopamine. It's not working all the time like some of our agonists that may cause problems in different ways. It is using your cells to make more dopamine when you need it. And so I tend to try to help patients in that way, because it does help us to be able to regulate the amount of dopamine that you're getting in, so that we know when you've got side effects, and we know when you don't have side effects, or when you're off, that we're able to choose how the dose actually works for you.
Yeah, yeah, that's a great point. Another thing we should probably mention at this point is exercise. We all have encountered people who feel like if they did a workout on the elliptical that morning, they don't feel as much need to take their medication. Now, this does not work for everyone. There's many people who do not have this response, but we've definitely encountered individuals who feel that a session of exercise is very, very impactful on their symptoms. And you wonder what exactly that exercise is doing to the brain in that moment. But we all know, and all movement disorder physicians know, that people who exercise are just better off overall for a whole variety of reasons. And it could be a direct relationship to how the brain produces and uses dopamine in that moment. And so just wanted to plug exercise right here at this point in the conversation, that if you're looking for a natural way to treat your Parkinson's, you cannot get more natural than exercise. I don't know if you want to add your 2 cents on exercise.
So true, so true. It is the spot that with my patients, I will not compromise. At every stage of Parkinson's, you are able to exercise. At every stage. The exercise you do may change, but you're able to exercise. And the cool thing is, in all the research, it didn't matter how intensive your exercise was. All of them helped people with Parkinson's do better. Whether we're talking about marathon running, or we're talking about Tai Chi and yoga, which yoga is actually pretty hard for me, so I don't count that as light exercise. It all helps people with Parkinson's do better. So the chair exercises that the APDA does, you may look at that and go, what is this doing? It is absolutely helping you. So every time at every stage, you should be exercising.
Absolutely. We definitely agree on that point. Rebecca asks a question about Chinese medicine and acupuncture, and what the role is in treating PD. And she's heard stories of people who've really had great benefit from acupuncture. Do you have any thoughts on, is that something you recommend for your patients? And what are your thoughts on use of acupuncture for Parkinson's disease?
Yeah, I think there have actually been some published data that have showed some beneficial effects of acupuncture. I don't know how it works. But again, this is one of those spots that if you go to a reputable person who does this and it is in a safe manner, I have no problem with people doing acupuncture. Because again, if I had a treatment that was disease modifying and a cure, and you said, I'm going to do acupuncture instead, and acupuncture had not been shown to be a cure, then we're going to wrestle. But because I don't have a cure for you, I've got treatments that help you do better. If you do acupuncture and for whatever reason it boosts your ability to produce dopamine, I'm not opposed to that. I just don't have good enough data where I can point to this study and that study that shows me, hey, this has been super effective. And that's the spot that I have to know my own limitations, that I don't have enough data to tell you do it or don't do it, but I'm not opposed to it as long as you're doing it in a safe way.
Yeah, I completely agree. I completely agree with that philosophy, which is my philosophy as well, which is basically, it would be so great if we had this algorithm that we knew exactly what to do and we make everyone better. And then we wouldn't have any questions. But I think it's frustrating for patients when they think of something, they come up with an idea, but we haven't come up with the idea. Why didn't
Yeah.
we come up with the idea that helps them? And I get that. I so get that. But it really comes down to data. Like we see hundreds of people. We can't be recommending something to hundreds of people without knowing that it works. But we're so happy if you find something that helps you. And then we can incorporate that into our thinking as well. So it's really a two-way street in the situation we're in. So come to us with your ideas. That's fine. That's good. We want that. So thank you, Rebecca, for that discussion about acupuncture. Oh, so many questions. So now Lori asks a question about vision changes, vision and Parkinson's disease. So Lori has blurred vision. What's the approach? Now, often we get asked, I have blurry vision. My ophthalmologist doesn't find anything wrong. My glasses are perfect. What do I do now? So maybe we can start with that question and hopefully Lori gets an answer.
Yeah, so blurred vision can often be that while your eye movements look normal, they may be not quite normal. So if your eyes are looking slightly different, then the way in which they create that image and it lands on your brain doesn't land quite right. And so sometimes that's blurred. And in people with Parkinson's, that can absolutely be a problem. And that's when we engage our colleagues who are neuro-ophthalmologists, and they may actually take a look at your eyes differently and think about, are there something to add to your lenses that's not about acuity, but about making your eyes see the same image in the same way? So that's a prism that may help your vision to be better. And so that's when I typically engage my colleagues in neuro-ophthalmology to see if that's potentially one of the issues that's going on to cause that. Lots of the medicines we use make people dry. And so dry eye can also be a problem for people with Parkinson's that can result in people having what they perceive as blurred vision. The ophthalmologists and optometrists are usually really good at catching that and potentially giving you drops to treat that. But that may be one of the things that we want to make sure we're also asking questions about.
Yeah, that's a great point and definitely overlooked by me as well. So thanks for that reminder. Okay, excellent question from Teresa. And I don't have the answer to this. How often should a person see their neurologist? Access to healthcare is difficult with long wait times.
Ooh.
How do we respond to Teresa?
When one of our colleagues did a study looking at how to best take care of patients with Parkinson's disease, the obvious thing that was different was that people with Parkinson's disease who saw a neurologist did better than people who did not see a neurologist. So the first answer is everybody with Parkinson's needs a neurologist. The second question of do they need a movement disorder specialist? We haven't actually answered that question yet. Yeah, I'd like an answer to that question because, that may make my business better, but we don't actually have an answer to that question yet. So we need neurologists who are well trained. The second part of your question is really hard, which is we don't have enough infrastructure in most of the country to actually be able to see Parkinson's patients in the time frame that we would usually want to see them. This is my goal of a practice, and if you talk to my patients, they're going to laugh when they hear this, but I think patients with Parkinson's need to be seen at least twice a year. but most of us can't do that. And so we have to think about a team-based approach. And so how do we include other folks that are well trained in the treatment of people with Parkinson's disease to be involved in people's care? And so that includes our nurses, our nurse practitioners, our colleagues in internal medicine who we're communicating with, to make sure that you have somebody where you can actually ask these questions of. We need more neurologists. That is absolutely the case. We need more students, residents to choose to do neurology. And we need more folks to really to kind of embrace the taking care of people with Parkinson's disease. That is a national, worldwide problem, but certainly impacts the ability for you to see a neurologist in the time frame that we would think is the right time frame.
Yeah, so we don't have great answers. Really, problem is acknowledged. That's the best we could do at this point. Thank you, Teresa, for that. So Kieran asks a question: is there a cure for freezing of gait? So freezing of gait is a very particular walking pattern that is seen in Parkinson's disease, where the feet tend to get stuck to the floor, and there's this sort of stutter step, marching in place look to the walking, where the front of the body kind of wants to keep going and the feet are stuck to the floor. It can be quite disabling and cause falling. So Dr. Ushe, what is a good answer for Kieran? What is a way to address this very difficult walking problem?
Yeah, so the simple answer is cure no, as in most of the things that we've got in Parkinson's, but management, yes. And so let's think about the strategies. The strategies are similar to everything else that we've been discussing. Is this tending to happen when you're off, meaning when the medicine has worn off on you? Is it not lasting long enough? That's the easiest of the ways, because then we just think about strategies to get you more medicine, or to be able to smooth out your effect of medicine so that you're not in the off state very long to get to that point of freezing. That's the majority of people who have freezing of gait. It's really an off-state phenomenon. And so we're either thinking about more medication, a different way to deliver medicine, or even thinking about strategies with deep brain stimulation. We have to be careful with deep brain stimulation because we've actually shown that we can induce freezing of gait with deep brain stimulation. So we have to be careful with the way in which we deliver deep brain stimulation. Now comes the on-state freezing of gait, or people that have both, or yo-yo phenomenon, where you're freezing, you turn on, you feel better, and then you peak and you start freezing again. And that's really hard. One of the best ways to treat freezing of gait, especially in patients like that, is actually physical therapy. So getting you to a physical therapist that can work with you on strategies to break freezing of gait, strategies like having a metronome or cueing that helps you to be able to break freezing of gait. Or even having a friend, loved one, caregiver be able to say a phrase to you like, take a big step over something that helps you to be able to break those freezes. There's strategies occupational therapists and physical therapists can do for you, such as giving you a cane or a walker that has a laser pointer on it, or a laser line that helps you cue so that you can break freezing. So both medical and non-medical strategies to hopefully keep you from freezing.
Fantastic. We have a question that was asked a couple times, so maybe we'll address it now. You mentioned deep brain stimulation. We know that you're very involved in deep brain stimulation clinically. And you sort of began to address this question, but maybe I'll ask it formally, which is, at what stage of Parkinson's should a person start thinking about deep brain stimulation or get deep brain stimulation? How would you think about that?
So the day you're diagnosed, you should be thinking about all of the things that are potential for you. So you should not take things off your plate and say, my goodness, I would never do that thing. And so learning as much as possible early allows you, when you're actually ready for it to be something that you proceed with and don't necessarily wait too long. So now comes, when's the right time to do deep brain stimulation? Well, deep brain stimulation is approved for patients with idiopathic Parkinson's disease, which is an important thing. Somebody asked about PSP earlier. I don't know if we're going to get to that, but you got to have Parkinson's. That means that levodopa works for you. That respond to levodopa, but the levodopa is now resulting in motor fluctuations, meaning that you have ons and offs. The doses are not lasting long enough. We're beginning to shrink your window. and you're having side effects from medication that keep us from giving you the dose of medicine that you need in order to do better. For the majority of us that do deep brain stimulation, we don't like to start DBS in the first 4 years of diagnosis because some of the other diseases that look like Parkinson's can very much look like Parkinson's in those first 4 years, which makes it difficult for us to know, do you really have Parkinson's or do you have something else? And to give you a brain surgery that, although pretty safe, is still a brain surgery with risk if you have little chance of getting better, seems like not a good thing to do. The group of patients where that maybe doesn't apply is the patients who have really bad tremor that otherwise are Parkinson's and have symptoms that respond to levodopa, but the tremor doesn't respond, and that tremor is affecting their daily lives. Those patients tend to progress to deep brain stimulation faster because deep brain stimulation is so good at making tremor better, and levodopa and other dopaminergic medications don't always make tremor go away.
Fantastic. So we have a question from Stella, which I want to address, which is a really good question, and wanted to make sure that we address this for anyone in the audience who it's applicable to. And that's, I'm 1 year into my Parkinson's diagnosis. What changes should I make? And just to address that for a second, I think the first question is answered by Stella being here, which is just learn what you can. And that's a double-edged sword because, as you said, Dr. Ushe, everyone's different, and what may be applicable to one person in your Rock Steady Boxing group is not necessarily applicable to you. So you have to take everything that you hear and sort of sift it through that idea, which is that it might not be applicable to you. Don't panic. Just hear all the information and sort of just take it all in without sort of personalizing it, that's something that's going to happen to you. But having said that, getting educated, writing down your questions, asking the questions that you have. And then the other piece to it is figuring out how to make moving and exercise more a part of your life. So there's some people who are natural athletes who've been athletic all their life. They love moving, they love sports, and it's very easy to make sure that movement is incorporated into their lives. But there are many people who do not find that to be particularly appealing activity and never really made it part of their life. So now's the time to change that, and to change it in any way you can. The more movement, the better. The more exercise, the better. And while it is true that any movement is better than no movement, as you said, getting that heart rate up for a certain number of minutes a week is really important to really getting that aerobic component in. So that would be another thing, Stella, to really focus on. And then you want to make sure you have a community. You want to make sure you have support. You want to figure out who you want to know about your diagnosis. It may be very stressful to keep that diagnosis inside or to kind of keep it and hide it from some people. That may be more stressful than actually telling people. So working through those issues, working through who in your life should know about this, who in your life can support you. So getting that education, that support, and that exercise in, I think would be the big three. So I'll throw it to you, Dr. Ushe. Anything else we should be advising Stella in her first year of diagnosis?
Yeah, no, I think you hit them. The big one being the exercise piece. You don't necessarily need medicine when you are diagnosed. Remember that we are treating symptoms. And so if your symptoms are not bothersome, are not causing balance trouble, and are not bothering you, they can bother anybody else as much as they want. If they're not bothering you, we don't necessarily have to start medicine. But boy, we got to start exercise. We got to be moving. And the other one I put in there is water. Drink that water.
Fantastic. So you mentioned that we had a question about PSP, progressive supranuclear palsy, that had come up earlier. And there were so many, I skipped right over that one. So let's get back to that one because we really should be addressing that before our session is over. Do you want to take that one? What is PSP? Harvey's asking this question. How does that relate to Parkinson's? And what can you do about PSP specifically?
Yeah, so you may hear the term Parkinsonism, which means looks like Parkinson disease. So there's several diseases that can look like Parkinson disease, and progressive supranuclear palsy is one of those diseases that looks like Parkinson disease. It tends to affect people in the same age group, maybe a little bit older, but tends to have a bit of a difference in the symptoms. In Parkinson's, we tend to see symptoms more on one side of the body than the other, while PSP, they tend to be more equivalent on both sides. We tend not to see tremor as much in PSP. It can happen, and we've certainly seen it, but we tend not to see it as much in PSP. And then the feature that people tend to think of, aha, that's PSP, is that people can have a trouble with moving their eyes, where their eyes don't look down as easily. And so they tend to fall earlier in the course of their illness. Interestingly, all of those things happen in Parkinson's disease. And so it really is hard to say for sure somebody has PSP when they're alive and you haven't looked at their brain. And since we don't have a new, different treatment for PSP than we do for Parkinson's disease, we tend to treat them the same. However, when we think about the pathology of the two diseases, they're different. So we talk about alpha-synuclein when we talk about Parkinson's disease. We talk about tau when we talk about progressive supranuclear palsy. People with PSP tend to have cognitive problems earlier than people with Parkinson's disease. But we earlier talked about Lewy body dementia, which you heard me say is not a different disease than Parkinson's disease. And so certainly people with Parkinson's disease can have earlier cognitive problems as well. And so really they can run alongside each other. The difficulty with PSP is that it tends not to respond to treatment as well as Parkinson's disease does. It tends not to respond to deep brain stimulation. So we don't offer deep brain stimulation for folks that have PSP. And so each of those things, as we're seeing you, we're trying to evaluate these subtle differences between the diseases that may help us make good choices, not bad choices for you.
Great. So we are nearing the end. We have a bunch more questions I'd love to get to. So let's try to get to a few more. Glenn has asked a question, and I really want to get to this question. He's asked it twice. So thank you, Glenn, for bringing this up again, which is what anxiety medicine is best for Parkinson's disease? People with Parkinson's. Anxiety is such a prevalent non-motor symptom of Parkinson's. How is that treated? So what do you give your patients, Dr. Ushe, for anxiety?
Sure.
How do you address it, I should say?
I start with levodopa because anxiety can be an off-state symptom. And it's a super common off-state symptom is people go, man, 30 minutes before my next dose, I get this creeping feeling or even sweating. And I'm just feeling like things are impending and are awful. And for that person, we don't necessarily need to add different medications. We can just add regular levodopa and they do quite well. And so that's one of the first things that you try to figure out is when are you anxious? The anxiety is really part of the underlying feature of the disease. And I also ask questions about mood because depression may actually be part of this. And I actually like to treat anxiety with antidepressants if I can, because they tend to have less side effects than what the things that we typically think of as anxiolytics. So the benzodiazepines and those kinds of medicines tend to affect cognition more, tend to affect balance more. And so I tend to avoid those medicines and use typical antidepressants or thinking about levodopa in the treatment of anxiety. And then you know what? Therapy works. Being able to talk through causes of anxiety actually works, and I don't have to worry about side effects except for time, and that may actually be the best way to treat anxiety.
Yeah, absolutely. Glenn adds a kind of caveat is his anxiety is worse in the morning. And I think that highlights what you were saying, that it's possible that when you're sort of without medication through the night and you wake up in the morning, and that could be a particular time where you feel the most that you need your medicine, that could be an indication that you're off, or that you need that levodopa to kind of calm that anxiety. So that kind of fits in with what you were saying. Paul asked a question, which I skipped over a little while ago, which we probably should get to at least at some point, which is, how do you know if you're on or off? What does that mean? So we probably should define those terms for those in the audience who are not familiar. So on, in our lingo, refers to a state in which your Parkinson's disease symptoms are well treated, and it typically correlates with a good amount of timing from your last dose. So you take your dose of levodopa, it may take a half an hour to kick in, and then you have some good time where the medicine's really working well, and then maybe the medicine stops working as well. So that period of time where it's working well, we call that the on time, and then the period of time when your symptoms are starting to return, that we call the off time. And some people have this sort of sine wave of their day, that they're on and they're off and they're on and they're off. We don't like that. We don't like when people have a sine wave. We want everyone to feel nice and even and on throughout the day and not have these fluctuations. And that's where some of these treatments we were talking about come in, where we're trying to get that response to be more even. The pump may help with that. The deep brain stimulation may help with that. And how do you know if you're on and off? Well, if you don't know, then you probably don't have ons and offs. If you can't tell that your symptoms are going up and down, then you probably don't have symptoms that go up and down. It's a very, it should be apparent to you that your symptoms are either there or not there. And so if you are questioning the ons and offs, then you may be one of the lucky ones who are even through the day. Having said that, what can be complicated is sometimes people have dyskinesias, which are sort of extra movements, which can be a side effect of the medication. And sometimes it can be confusing whether those movements are tremor, or shaking, or a rhythmic shaking from Parkinson's, or a dyskinesia, which is a more erratic sort of movement from the medications. Sometimes it can be very tricky to discern that and to figure that out. And when that happens and somebody isn't quite sure what's going on, we often ask them to videotape the period of time when it's a little bit confusing. And sometimes from our perspective, it's very clear what's going on, but it isn't as clear to the person. So sometimes a video can go a long way to really clarify what's happening when in relationship to medication. So hopefully, Paul, that answered your question. So we have an amazing question from Mary. I'm gonna get Dr. Ushe to answer this one. Can you talk about genetic testing? So Mary herself does not have Parkinson's, but has two brothers with Parkinson's. So what should Mary do about genetic testing? And some other members of her family presumably may be interested to know the answer to that.
Yeah. So if it's part of a study, I would say go for it. If it is for you, I don't know what to do with that information yet. I don't have a way to keep you from getting Parkinson's. I don't have a recommendation that you're for sure gonna get Parkinson's, because the majority of the genes that we have are susceptibility, not necessarily, 100% you're gonna get it. And so from that standpoint, I would not use gene testing as let me get this test and it will tell me that I'm gonna get Parkinson's. There's lots of studies that we've got going on around the country, around the world, that are wanting to do gene testing so we can actually answer those questions. And so that would tend to be, especially if you've got a family history in your family of Parkinson's, that would be great to be able to engage with a center that is doing research. We're trying to get better at research. For a long time, we thought returning results to patients was not the right thing to do. But we're starting to change and starting to go, you know what? We do need to return results to people who've done research, but it does require the counseling of somebody who really knows genetics to be able to talk you through what does this result mean for you. And then, in the world that we live in, it affects insurability when things like this get out for you. And so there's a chance you may never get Parkinson's, but if some company gets a hold of, hey, it shows that you've got a locus of susceptibility here for your Parkinson's, it may mean something for you getting health insurance, less with health insurance with the Affordable Care Act, but life insurance, those kinds of things may be more affected by the fact that you know that you have a susceptibility to Parkinson's. So I tend to say to folks, do it as a part of a study, not in a clinical way, because I don't know what to do with that yet clinically.
Yeah, very complicated. Thank you very much for that answer. We are really at the end of our time. We're going to do one last question, and then we're going to have to say goodbye. Thank you so much, everyone, for your amazing questions. So here's our last question. It's from David. Dementia, or cognitive problems that affect how people do their activities of daily living, has made it harder for my brother to follow directions from a physical therapist. And you mentioned movement and therapy is important at every stage of Parkinson's. So how do you best advise a person like this to keep moving when they're having a hard time following the instructions given? Good question.
Yeah, so physical therapy gets difficult as people have more and more cognitive impairment. However, our physical therapists, especially those that are well trained in Parkinson's, are actually quite good at figuring out what patients can and can't do and how to help train family members and caregivers, care partners in assisting them in doing that thing. And so my typical advice is go to a PT that knows what they're doing with Parkinson's. Even if they're far away from you, one visit with them may help your local PT be able to enact a plan that actually allows your brother or your loved one to be able to move well. Chair exercises, bed exercises, any of those things that keep people moving, but indeed reduce their risk of falling, are important as we proceed with the disease.
Great, thank you so much. So again, that is all the questions we have time for today. So don't go anywhere. We do have one final special guest coming on. And if you did post a question that we did not get to, please copy that question now and post it in the remaining questions from sessions message board in the community section of the Whova platform, which you hopefully have seen. And we will do our best to answer all the questions that are posted there. So please go ahead and do that now. And I want to thank Dr. Ushe for being here with us today. I want to thank all of you for being with us today and asking all your questions. If you're interested in other conversations with Parkinson's experts and like to learn more, we have a great series called Dr. Gilbert Hosts, which is on YouTube, where I talk with experts every month. And hopefully you will join us for that, for past sessions and for future sessions as well. So to close out our day, I want to welcome back Leslie Chambers, APDA's President and CEO.